Hello, good morning, everyone. Welcome to the breakfast at the Faculty of Medicine. This is an effort to continue CME with live webinar. Today, I'm your moderator, Professor Imran Zainal Abidin from the Cardiology Division. And today we are fortunate to listen to two eminent speakers. One from the rehab medicine, and the other one is from my own unit cardiology. Yeah. To start it off, let's some housekeeping announcement. If you are keen to ask questions, which you are encouraged, please use the Q&A button instead of chat button, so that we can look into the questions without missing any of them. If you use the chat button, then it might just go up and I might miss the questions altogether. Secondly is that for every talk, every session, every speaker, they are given about 30 minutes. So we will try and include about 5 to 10 minutes at the end of each lecture for question and answers. Yeah. So if you can just hang around for the end of the each speaker's lecture for us to answer your questions. Yeah. Without further ado, it's an honor for me to introduce the first speaker, Professor Siew from the Rehabilitation Medicine. Now, if you read her CV, it was impressive. From someone who started with a diploma in occupational therapy, she has risen the ranks all the way up. She has been awarded 11 awards in 11 awards, wrote 5 books and a few chapters as well, and more than 100 over ISI publication. Yeah, so you should be applying for full prof. Anyways, her passion is actually in the management of patients with cancer. Okay, it is something new. How does cancer relate to therapies? So let's listen to, without further ado, listen to Dr. Siew presentation on surviving cancer.
A very good morning to all of you, and thank you so much, Prof. Imran, for chairing the session and the kind introduction. I'd like to just quickly start off with my slides. I've chosen this title because of I have things that block my presenter view. Sham, how do I remove?
You can just drag it away.
I can drag it away. It's all the, no, it doesn't. It blocks my presenter view. Oh dear.
You can just close the window because we don't see all that.
Close my window.
No, just close whatever is blocking your view.
It's all the video of Prof. Imran and all these.
I just drag it to the side.
Okay, thank you so much. Again, I apologize for all this. So this is my objective. I hope to cover some pertinent background and rationale, share some model of care in this area, and share some of the research that we conducted, and end with some reflection. So to start off, there are 2 things to highlight from this new global cancer statistic. Number of new cases in 2020 is 19 million worldwide and about 49,000 in Malaysia. 45-year survivor, they are now 50 million globally and 128,000 in Malaysia. Who are these cancer survivors? Now, previously, it refers to survivor at 5 years after diagnosis. Currently, cancer survivors are those from the time of diagnosis through the balance of life, and it includes family members and significant others. Now, in 2005, Institute of Medicine published a paper from cancer patient to cancer survivor, and this has changed the landscape of care and research from largely focusing on cure and medical treatment to a wider coverage to cover all the after effects of cancer, as well as the non-medical challenges, including building health and wellness through the balance of life. So the definition of supportive survivorship care now refers to any treatment or services to help people to cope with the numerous consequences through the balance of life. Now, what is the current trend of cancer survivorship? CDC USA reported that there's a 26% drop from 1999 to 2018. Now, over this 2 decades, 67% have survived over 5 years, 45% survived 10 years, more than 10 years, 18% survived more than 20 years. So the 15 million in 2019 is now projected to rise to 22 million in 2030. And in Malaysia, this is my case study looking at period of diagnosis from 2007 to 2011 and follow up to 2016. Now, the 1-year survivor and the 5-year survivor across all cancer types is projected here, and 1-year survivor is much better than 5-year survivor. Now, this slide suggests that more work and studies needs to be done on how to improve survival over a longer period of time, including lifestyle, functional, productive activity, participation to reduce risk. Now, this slide shows that for Malaysian male, survival is better for prostate, thyroid, and colon, and for female, it's better for thyroid, breast, and colon. When compared to some other countries, looking at the top 2 cancer, breast and colorectal, Malaysia is only slightly better than Thailand and India, again suggesting more work needs to be done in this area. Now, overall, survival for most cancer will continue to rise, and people are living indefinite period with the diagnosis. But 15 years ago, many would not accept cancer as a chronic illness. In 2006, I submitted a poster to the World Cancer Congress at Washington with the title, "Is Breast Cancer Becoming a Chronic Illness?" And I was granted a very generous scholarship. Now, at that time, many reviewers felt strongly that addressing cancer as a chronic illness is akin to trivializing the seriousness and fatalistic nature of cancer. But today, people are more accepting of cancer as a chronic illness and, taking a form of chronic illness that people are living longer with it. Now, what are the impact of living with cancer? Cancer treatment has its numerous side effects from the various treatment. Now, some of these effects are known, but as we live longer, we are beginning to know some of the new late effects, and many of these can affect functional activities and quality of life. As an example, a very new PhD thesis published this year reported that late effect of testicular cancer with platinum-containing chemotherapy has high mortality and morbidity risk from colorectal malignancy and as well as heart failure. And from an occupational perspective, the how and why of cancer survivors' participation in activity has been impacted by cancer and its treatment, and how their occupational role and the environment can impede or facilitate their daily functioning has key implications for survivorship care. As an example, Harrison and colleagues did a systematic review and highlight numerous varying unmet needs in all this area, and these are mostly non-medical, requires non-medical management. Now, these unmet needs appear to be highest and most varied during treatment, but majority of them expressed that these unmet needs were at post-treatment phase, which again suggests that some level of supportive therapy at post-treatment is needed to enable those affected to function safely and independently. Now, approximately 42% of cancer cases and 45% of cancer death in the USA are linked to lifestyle factors. In the field of occupational science, the term occupational perspective is widely used to guide research and care as a way of examining about human doing and functional lifestyle. As more than 4 in 10 cancer and cancer death is linked to modifiable risk factors which are linked to their lifestyle in their remaining days, this is an important gap to address. These effects have negative implication on the person's daily occupational performance domain related to physical, social, psychological, spiritual, as well as occupational well-being. And in just looking at the occupation, there are about 8 areas of activities of daily living: instrumental, ADL, work, education, leisure, social participation, as well as basic self-care. And all these alter the person's lifestyle and impact on their quality of life. Now, I'm going to just share about some of the studies conducted and categorized under this broad domain. I will start off with the 4-week self-management program. This is a intervention for women with cancer with SF36 as our main outcome. Consists of 4 phases. Phase 1 is modeling the program based on the needs expressed in the focus group, and then we piloted in phase 2, and phase 3 we conduct the control trial, and we follow them up 2 years later in phase 4. Now this graph shows the quality of life of women in the experimental and the control group. Quality of life increases over time for both groups, but there was significant difference and higher score for experimental group, and it was significantly different. So I wanted to know, what is the quality of life of our cancer survivor, compare them to normal healthy people. So I plotted all the subscales of SF36 and matched it to Asman's study on healthy Malaysians and Bowling study on healthy British women. And you can see the graph that, at 2 years after diagnosis, their quality of life is still way down. With psychological impact, I look at stress, anxiety, and depression, and I plotted experiment on top of the control group. So this is the T2 and the T4 score, T2 and T4 score for stress, anxiety, and depression. And you can see a trend of reduction in psychological distress over stress, anxiety, and depression. But only anxiety, the differences between group for only anxiety is significantly different. We also look at how they perceive impact of problem profile after their diagnosis. And the experimental group perceived less negative impact across self-care, mobility, and etc. And there is also a significantly higher confidence level. These patient self-management studies have been published in Journal of Cancer Survivorship and also as a book. And it was also selected as one of the 3 finalists in the UK BMJ 2011 Getting Evidence into Practice. This study is about the Kuala Lumpur Zigong study and incorporating Zigong and breathing as a 8-week intervention. We found that the Zigong group has significantly better quality of life than the placebo group, which is actually just aerobic session, and control group, which is usual care. And in the aerobic group actually has continued on their activities at our center point, and they have even registered themselves as the Candy Girls, and they've been pretty popular. Now, another area that is lacking in research is cognitive impairment in cancer survivorship. We've done quite a bit with our Australian counterpart. Very briefly, we found a general lack of recognition and acknowledgement of chemo brain as an after effect or late effect from treatment. However, our cancer survivors reported that chemo brain is a real experience, and there is a persistent but inconsistent impact on function, and some of their simple function can turn into very complex. All this affects their independence in functioning and in their daily life. And we also did studies on the oncologists, and we find that both Australia and Malaysian oncologists are not are lacking in recognition for the issues on chemo brain. Now, this is the study on return to work. Focusing on paid employment. Briefly, our study shows numerous barriers and facilitators for work across the 3 ethnic groups. What I want to highlight here is that the prevalence of return to rate at 1 year after diagnosis is only 32%. You compare that with USA, it's 93% and 82%, and even South Korea is 58%. Now, clearly more longitudinal studies are needed to examine this in greater depth, and how cancer can impact return to work and functioning at work. Now, in this study, which is an extension of one of our student study, and I just want to highlight that we found that there is a 21% loss and reduced mean income within 1 year after diagnosis, with significant financial burden on them. Now, the European Agency for Safety and Health at Work reported that the risk of unemployment in cancer survivor is 1.4 times higher than among people who have never been diagnosed with cancer. We don't have data on Malaysian, and this is another area that we need to look at. Return to work with colorectal cancer survivor. Again, there were lots of facilitators and barriers. And you can see most of these challenges are actually non-medical factors. Now, in this study, we mapped occupational participation of colorectal survivor in these 4 domains. And our findings suggest that there wasn't a significant relationship with quality of life, but it was mediated by meaningfulness of the activity that they participated. Now, this has important implication for intervention to support cancer survivor in promoting healthier lifestyle through their remaining life. Now, in the definition just now, I said that families are also considered as cancer survivors. So in this study, we are looking at adolescents from 50 families with either a mother or a father who has been diagnosed with cancer. Now, some of our key findings were, female adolescent had a significantly lower quality of life than male adolescent, suggesting that they were more impacted. And adolescent with a mother having cancer rather than a father having cancer showed significantly lower academic functioning. And overall, adolescent living with parents with cancer has significantly lower score on emotional functioning. Findings on some of these studies that I've just shared show that there are numerous impacts in daily functioning. Now, moving forward, models actually helps to direct our focus and studies on cancer survivorship area. And this chronic care model with self-management support and community resource is actually particularly suitable and timely now for those cancer taking a form of chronic illness where people are living longer with it. This is the model of occupational participation for survivorship, which we developed in 2016 as a model to direct more occupational-based study and give it some scientific basis to it. Now, it focuses on enabling survivor to move from point 1 health condition before cancer to point 2 health condition after cancer, and to support them to rebuild health through meaningful activities. To do that, cancer survivors are supported to rebuild their lost functional body function, and then to help them to re-engage in daily activity functionally, and so that they can resume their participation and roles in life with consideration of their personal factors, as well as the environmental factors that may impede or promote participation. This model is holistic, and it actually considers more the non-management aspect as well, the tasks that people with chronic diseases need to self-manage in order to live with the condition. And some of these are like emotional management that comes with the disease, and roles and relationship management. And these are often neglected in the medical model care, but are very important for cancer survivorship to rebuild a healthy lifestyle, living through the indefinite period in the community. It is timely now that there should be more translational research and a greater shift towards community intervention to support cancer survivors living through their balance of life. Issues like cancer stigma, cancer myth, health literacy, community support are all important social determinants to enable better functioning of cancer survivors in the community. And all this requires a lot more studies. Community work is more effective for this rising group of post-treatment cancer survivors, but also to prevent an influx back into the hospital-based intervention, which should be focusing on patients still undergoing active treatment. Second last slide. This is just to encapsulate the many aspects of survivorship care that needs to be considered, since many of these physical, psychosocial, occupational sequelae can last for years and has implication on their occupational participation and productive activity by reducing their functioning capacity in their ADL work and leisure. Thus, an occupational perspective actually helps direct and give the scientific basis to the form of supportive and community care intervention that can promote health through their balance of their life. In conclusion, cancer survivors are occupational beings and occupational in nature. And from the occupational science perspective, engaging in their healthy, functional daily occupation should be the focus to promote better quality of life in the community. And so I end with this slide on reflection. Cancer survivor is a rising population. More work actually is needed in terms of research and practice and care. Both cancer survivorship and occupational science are emerging areas. But I want to highlight the two themes from my experience in this area, and this is occupational-based focus of research and care, as well as community focus for post-treatment for this rising group. I end by acknowledging all my funders, collaborators, students, and who have participated in one way or another, contributing towards the evidence base in this work. And with that, I thank you for your attention.
Thank you very much, Professor Lo. That was very impressive talk on the cancer survivor rehabilitation. So there's no question being posted yet, so maybe I just get the ball rolling. Uh, what about, is there, what would be the biggest problem or hurdle that you see in Malaysian perspective with regards to surviving cancer and rehabilitation? What would be the biggest hurdle that you wish that you can overcome?
Along the continuum of care, that at every junction from the diagnosis, detection, and all this needs to look at. But this area that I'm highlighting is people at post-treatment whom we haven't been looking at, and because of better survivor, we need to actually look into this. And when you talk about occupational base, we in Malaysia, we also don't have the manpower. I have been stressing this, that the entire 33 million population, we have only less than 2,000 occupational therapists. And we actually need some of these, occupational therapies to look into this area of work and ADL and help them to be more functional, using functional activities as a holistic approach. So clearly, the public university should be, looking at how to, produce more of this workforce and ensure that they are actually educated at the university level. In Malaysia, we still have this diploma level education, which is very colonial days model. We should move, but I think in a medical model, sometimes it's hard to get the information to the right people.
Great.
That's my view.
Yeah. So it has never occurred to me that after cancer treatment is completed medically, that the one should be referred to the to rehab medicine, because I myself, having parents with cancer, we've never gone through that process. Perhaps the realization of such services is available, that surviving cancer after the disease is being treated is a chronic issue, would need to be highlighted among the physicians, or the surgeons involved. Okay, we do have a question now. Let's see. Most cancer patients have depression. What proportions are just being treated with antidepressants instead of getting them engaged in activities as a way out? So you will answer live, yeah?
This is a very important question. A lot of the time we think that people with depression, or we wait for them to get their depression, full-blown depression, and then refer them to psychiatrists. It is important, but, to prevent, many times, just the supportive care community group will help them to prevent from, sliding down into all these, difficulties. Sometimes the supportive care is important, the community work is important, giving them some support is actually important, helping them to rebuild confidence, to participate back into life. The slides that I show on return to work, many of them is non-medical tasks related to psychological issues. Having to deal with family member, what to tell the family member, having to deal with the neighbors, having to deal with colleagues at work. And a lot of these are very counseling related issues that you can actually intervene before they fall into problems.
Okay, I have another question in the chat box, and I find this quite relevant. How do we differentiate this group of patients who have post chemo or treatment problems? Yeah, how do we differentiate them, or maybe because most of them are being labeled as attention seekers. Maybe they are labeled as they are lazy, want to find a way out, maybe get so whatsoever. And so the question was, how do we make our colleagues and the bosses understand these issues without labeling them, this group of patients, as attention seekers?
I think to start off, if a patient comes to you with some problem, you have to, accept it as they are having problem. I don't think we want to label people as attention seeker. There's lack of understanding, and just like I show on the chemo brain, we have a lot of feedback from the doctor say, oh, this is just stress, it's nothing to do with chemo brain. But from the patient's point of view, this is very real. It affects my function. So whatever is real needs, we need to take regards to that. And sometimes the issue is, when patients goes to medical doctors, you don't have the time, because you're concentrating on the medical aspect. So, you don't have the time to deal with this kind of thing. And how often I get feedback from patients say, the oncologists are so busy, we never seen them. I mean, it's true, we don't have enough oncologists. How can you go in and talk to them about non-medical issues? So this is where the other health discipline needs to come in. The counselors, the psychologists, the occupational therapists, they must come in, And also, as I say, community intervention is important because then you address the fault and you prevent some of these issues. Social prevention is actually very important. So all this have got to come in slowly, because we are just seeing the rise in cancer survivor, and we haven't actually have anything, and we have low manpower in many other areas of health discipline.
Yes, true.
Yeah.
Okay, thank you very much, Professor Loh Siew Yim, for that wonderful talk.